about a patient with ear infection. So, the objectives for this report is to inform the audience the relevance of ear infections to dentistry, to provide understanding on how to manage patients with ear infections, and to provide information about the physiology of ear infections. So first, we have our subjective information. So general data. We have a patient here. She is a 65-year-old female. She's Roman Catholic with the initials of BBC. Now her occupation is a household helper. She is a single woman and she is Filipino. So what brought her in today? The chief complaint, dental, is related to paroxysm. And on the medical side, she's been dealing with ear itchiness for 4 days on her left side. So, history of present illness. According to the dental side, the patient was fond of eating sweets and has night bruxism. She noticed that her teeth were aesthetically not very pleasing. The patient had her teeth extracted when she was still in high school, and she's been wearing the same complete denture for 15 years now. According to her medical side, 6 months prior to consultation, the patient was last seen at the ENT outpatient department with a discharge diagnosis of CSOM. This was chronic tympano-membrane perforation, AU, profound hearing loss, AU. 1 week prior to consultation, the patient noticed with yellowish, purulent, non-foul smelling discharge associated with itchiness on her left ear. She applied otic drops, ciprofloxacin, 3 milligrams to 1 milliliter on the affected ear. She took 3 drops daily, 3 times a day, and this provided relief with no further medical consult. 5 days prior to consultation, the patient noted yellowish, purulent, non-foul skin discharge with no associated itchiness, pain, fever, or bleeding. No interventions were done and no medical consult was done. 4 days prior to consultation, the patient noted yellowish, purulent, non-foul smelling discharge from the right ear with associated itchiness. She also applied her otic drops, but this did not offer any relief. So on the day of consultation, the patient complains of ear itchiness for 4 days. Also, along with her history of present illness, she is negative to tinnitus, negative to vertigo, negative to ear aches, but positive to infection and positive to discharge. Now, her past medical history. The patient has not had any dental work done since her teeth were extracted when she was in high school. She has had a complete denture for 10 to 15 years now, yet all of her teeth have been worn down with bruxism, and she has fair gingival conditions and fair oral hygiene routine. Past medical history. 4 years prior to consultation, the patient has had arthritis, but no medication was taken. 3 years prior to consultation, the patient had dyslipidemia, previously maintained with atorvastatin 80 milligrams. And 1 year prior to consultation, the patient discontinued the medication. According to her personal and social history, this patient is a 65-year-old household helper. She is not married. This patient is a non-smoker, non-alcoholic beverage drinker, and denies any use of illicit drugs. She sleeps 6 to 8 hours in average per night, and the patient is well nourished. Moving on to review systems. General and skin, there are no abnormal findings. Next is head and eyes. There are also no abnormal findings. Next is throat and neck. There are no abnormal findings. According to her breast and respiratory system, there are no abnormal findings. Cardiovascular, there are also no abnormal findings. Gastrointestinal, she has a very good appetite, but there are no abnormal findings. Her bowel movements are normal as well. She usually goes once daily, but sometimes it may take 2 to 3 days for movement. According to her urinary and genital, there are no abnormal findings. Peripheral, vascular, muscles, bones, joints, and legs, there are no abnormal findings. Psychiatric, neurologic, hematologic, there are no abnormal findings. Endocrine is also normal with no abnormal findings.
General survey. For the medical, we have the patient is alert and awake, ambulatory, afebrile, having a hard time hearing, having a hard time walking, not in cardiorespiratory distress. For her vital signs, her temperature is 36.9 degrees Celsius. TB is 140 over 90 mmHg. Pulse rate is 65 bmp. Respiratory 18 ppm. Weight and height data is not provided. Also the BMI. For her physical examination, her skin is normal, hair is normal, scalp is normal, eyes is normal, ears, nose and sinuses is normal, throat is normal. For her oral cavity, first is extraoral examination. Symmetry of her face is asymmetrical. Temporomandibular joint, the flaking and pink swelling is absent. Swelling is absent. Lip examination is normal. Lymph nodes is not palpable. Facial profile is straight. For her intraoral examination, her oral hygiene is fair. Gingival color is straight. Consistency of the saliva is smooth. Pathological condition is normal. Tongue is normal. Position of tongue is normal. Occlusion is not indicated since she doesn't have hurt. Intraoral examination, occlusal and proximal caries is not indicated. Root fragment not indicated and indicated for extraocular. For her physical examination, neck and thorax and lungs is normal. Cardiovascular, breast is normal. Genitalia, rectal is normal. Extremities, musculoskeletal is normal. Neurologic, cranial nerves, motor, cerebellar, and sensory is normal. For her assessment, first we should know what are the chronic suppurative otitis media complications. CSOM produces a chronic mastocytic contagious spread, erosion of the walls of the middle ear and mastoid cavity, which are rare and leads to exposure of facial nerve, jugular bulb, lateral sinus, membranous labyrinth, and temporal lobe dura. Contagious or hematogenous spread of infection to the brain produce similar permanently disabling potential fatal complications.
Diagnostic plan, the dental preliminary and final dental impression for complete denture, fabrication of complete denture, and for the medical, avoid ear manipulation, water precaution, keep the affected ear dry, continuation of topical antibiotics 3 times a day, and for the pharmacologic dental, non-pharmacologic dental, fabrication of complete denture and upper and lower. For the therapeutic plan, medical, non-pharmacologic, anti-inflammatory drugs, antimicrobial drugs, oral antibiotics, and topical antibiotics. For the pharmacology, water consumption, avoidance of tobacco smoke exposure, smoking cessation. So what to know about otitis media? An ear infection or otitis media is the most common, often a bacterial or viral infection that affects the middle ear. The air-filled space behind the eardrum that contains the tiny vibrating bones of the ear. Ear infections are frequently painful because of inflammation and buildup of fluids in the middle ear. Otitis media can cause by ear infection, caused by bacterium or virus in the middle ear. This infection often results from another illness. could be flu or allergy that cause the congestion and swelling of the nasal passages, throat, and eustachian tubes. For the reliever medication, antibiotics, and other prescription, treatment depends on the cause and severity of the infection. Over-the-counter medications like acetaminophen, Tylenol, and ibuprofen or Advil. Decongestants or antihistamines like pseudoephedrine or Sudafed or diphenhydramine or Benadryl. So, for our journal, it is the correlation between otitis media and mental malocclusion in children. So, for the researcher's objective, it is to determine the possible correlation between otitis media and dental malocclusion in children. For the background of the study, acute otitis media is a middle ear infection usually caused by bacteria or viruses that affects both children and adults. Next to the common cold, ear infections are the most common childhood diseases. Symptoms may include ear pain, decreased hearing, fever, and drainage from the ear. Recurrent acute otitis media is defined as 3 episodes within 6 months or 4 or more episodes within 12 months. For several studies in the literature investigated the association between otological symptoms and maxillary anatomical alteration and evaluated possible correlation between tubal dysfunction and stomatomatic system, and the association between malocclusion and otitis media in children has long been discussed. Some authors showed a significant correlations between deep bite and otitis media. So for our significance of the study, to have a further knowledge in handling the patients with otitis media. The methodology of this study is 50 subjects, including 26 males and 24 females. The mean age is 7 to 8 years old. 25 patients with otitis media formed the study group, while 25 healthy subjects formed the control group. The inclusion criteria included the mixed dentition after the eruption of maxillary and mandibular permanent first molar, and the maxillary and mandibular dental cast available. Otoscopy was performed with otoscope to evaluate the path to the eardrum and the presence of perforation. Dental occlusion was analyzed on the dental models in order to evaluate vertical, sagittal, and transversal problems. The investigators was blinded as to control and study group models during model analyses, and the presence of unilateral and bilateral crossbite was investigated. So the hypothesis of the journal is alternative hypothesis, because there is a correlation between otitis media and dental malocclusion in children. The result of this study is there is a significant correlation was found between otitis media and enlargement of adenoids. Significant predominance of posterior crossbite was found in the study group in comparison to the control group. No correlation between otitis media and overbite, angle class relationship, or inadequate oral habits were found. For the conclusion, the data of this study demonstrated a significant correlation between otitis media and posterior crossbite in children. Hypertrophic adenoids and tonsils were associated with otitis media. No significant correlation was found to tongue sucking, atypical swallowing, and mouth feeding. For the expert's opinion, it is from Dr. Alfred Valera. He said that in my years of experience, I haven't had any pediatric patients with otitis media, but in my understanding, there is no really significant between otitis media and dental malocclusion in children. Furthermore, habits is a must or a primary cause for dental malocclusion in children. For example, a patient who are used to tongue sucking develops an ear open bite. Thus, proper management and prevention should be
Acute otitis media. What is acute otitis media? Acute stands for abrupt onset. Ot stands for ear. Itis stands for infection and inflammation, while media stands for middle ear. So, acute otitis media means inflammation of the middle ear. What are the stages of acute otitis media? 1. Stage of tubal occlusion. Since the middle ear drainage is entirely dependent on eustachian tube. The first step in acute otitis media is the blockage of eustachian tube. Children are particularly predisposed to acute otitis media because their eustachian tube is shorter, wider, and more horizontal as compared to adults, which increases the chances of the eustachian tube getting blocked. 2. Stage of pre-suppuration. After the eustachian tube is blocked, the microorganisms start infecting. 3. Stage of suppuration. This is marked by formation of pus in the middle ear. Tympanic membrane starts bulging to the point of rupture. 4. Stage of resolution. The tympanic membrane rupture with release of pus and subsidence of symptoms. Inflammatory process begins to resolve. If proper treatment is started early, or if the infection was mild, resolution may start even without rupture of tympanic membrane. 5. Stage of complication. If virulence of organism is high or resistance of patient poor, resolution may not take place and disease spreads beyond the confines of middle ear. Treatment. 1. Antibacterial therapy. It is indicated in all cases with fever and severe earache. 2. Decongestant nasal drops. Nose drops should be used to relieve eustachian tube edema and promote ventilation of middle ear. 4. Analgesics and antipyretics help to relieve pain and bring down temperature. 5. Ear toilet. If there is discharge in the ear, it is dry mopped with sterile cotton buds, and a wick moistened with antibiotic may be inserted. 6. Dry local heat. It helps to relieve pain. 7. Myringotomy. It is incising the drum to evacuate pus, and is indicated when A. Drum is bulging and there is acute pain. B. There is an incomplete resolution despite antibiotics when drum remains full with persistent conductive deafness. C. There is persistent effusion beyond 12 weeks. All cases of acute suppurative otitis media should be carefully followed till drum membrane returns to its normal appearance.